In this Medicine in Minutes, we are going to discuss the opioids, which are strong painkillers. We are going to discuss the three more well-known opioids, which are morphine, oxycodone, and fentanyl. Oxycodone and fentanyl are synthetically produced opioids, whereas morphine can be naturally extracted from the papaver plant. It is one of the oldest and most well-known painkillers known to man. Nowadays, morphine can also be produced synthetically. Opioids work as strong agonists on, you guessed it, opioid receptors. This gives its pain-killing effects. There are several opioid receptors, which are the mu, kappa, and delta receptors. The mu receptor, however, is the most important when it comes to the pain-killing effect. These mu receptors can be found in the central nervous system and in the gastrointestinal tract. Kappa and delta receptors induce the pain-killing effect to a lesser extent and are more involved in inducing sedation and a feeling of euphoria. Opioids are on the third and fourth step of the so-called pain ladder of the WHO. The first steps are paracetamol and NSAIDs. When these drugs are insufficient, or if there's a contraindication to use one of these classes, opioids are the next choice. There are different preparations of opioids available. Think of a drink variant, suppositories, tablets with or without regulated release, sublingual tablets, nasal sprays, transdermal patches, and intravenous and subcutaneous administration. To optimize the treatment, a choice between these different preparations can be made based on patient wishes, the setting of the patient, and the kind of pain. For chronic pain, tablets with regulated release or a transdermal patch have the preference. This way, the pain-killing effect can be sustained over a longer period of time because of the slow and regulated release of the opioids. For acute pain and as a rescue medication, fentanyl nasal spray or regular oxycodone tablets without regulated release can be used. In a clinical setting, parenteral preparations are usually applied, with, for example, subcutaneous, intramuscular, intravenous, and epidural administration. This way, the dosage can be more easily adjusted based on the concentration of the preparation. It is also more convenient for the quick relief of the pain. This is because the opioid reaches its target receptors a lot quicker. For fentanyl, it is important to be wary of the nasal and transdermal administration of the route. With the nasal spray, the patient should be properly instructed how to position the bottle when in need of rescue medication. For transdermal patches, it is important to check for the location of the patch. Is it applied at the location where the patch is stable, and is it comfortable for the patient? You should also check if the previous patch has been removed before applying a new patch. Premature switching of fentanyl patches can lead to an increased concentration. Monitoring of renal function is important with morphine use. Morphine has an active metabolite, which is called morphine-6-glucuronide. These metabolites get excreted via the urine. When the renal function is decreased, this active metabolite accumulates, which leads to a higher and longer exposure. Therefore, it may be necessary to decrease the dosage or dosing frequency when renal function is decreased. For fentanyl and oxycodone, adjustment of the dosage is not needed with a decreased renal function. The liver plays an important role in the pharmacokinetics of opioids as well. In the liver, these three opioids get metabolized. The three glucuronide variants of morphine and norfentanyl are inactive metabolites, but noroxycodone and oxymorphone are active metabolites. As a matter of fact, oxymorphone has a pain-killing effect that is 14 times stronger than regular oxycodone. These metabolites get converted to inactive metabolites and are excreted through the kidneys. When the liver function is decreased, less metabolism takes place and exposure to the opioids increases. Therefore, it may be necessary to decrease the dosage. Also, the intestines should be taken into account when prescribing opioids. a well-known issue is obstipation. As you may remember from before, opioids also bind to mu receptors in the gastrointestinal tract. Activation of these peripheral mu receptors can lead to increased peristalsis of the intestines. This adverse drug reaction, or ADR, can continue over a longer period of time, unlike ADRs such as sedation or nausea, which normally alleviate after a couple of days. Because of this, a laxative is advised next to the use of opioids. Another important ADR is respiratory depression or hypoventilation. This is also induced by activation of mu receptors in the central nervous system. Respiratory depression mainly occurs in patients who already suffer from breathing problems, such as patients with COPD. This can have fatal consequences when not treated on time. Luckily, the respiratory depression and hyperventilation can be treated with the antidote, naloxone. This is a short-acting opioid receptor antagonist, which blocks the effect of opioids, including the respiratory depression. Since the half-life is much shorter than all the opioids, and in case of addiction, acute withdrawal effects can occur. Therefore, use of naloxone should be limited to life-threatening situations or in case of uncertainty about the intoxication as diagnostic. When opioids are given with certain other medications, the risk of ADRs are increased. This is especially true for depressants of the central nervous system. Think of alcohol or anesthetics or benzodiazepines as a sedative. You should be wary of these interactions as the increased risk of ADRs may have dangerous consequences for the patient. Decreased respiratory rate and blood pressure can still be treated in time, but it may also lead to and has led to death in severe cases. As you saw in the previous slide also, certain CYP enzymes in the liver are involved in the metabolism of opioids. Therefore, interactions involving these enzymes should be taken into account. Inducers of CYP3A4 and CYP2D6 will lead to a higher rate of metabolism. Conversely, inhibitors will lead to a lower rate of metabolism. For example, the anti-epileptic carbamazepine is a strong CYP3A4 inducer, which thus leads to increased metabolism of oxycodone and fentanyl. This leads to a lesser exposure of oxycodone and fentanyl, and on the other hand, inhibition will lead to a decreased metabolism and a risk of overdose. With frequent use, addiction and tolerance are often observed in opioids. It's still unclear how this tolerance develops. The dose, however, may need to be increased when the pain increases. It could occur that increasing the dose does not give the effect that you aimed for, or that more ADRs will occur. In that case, it is possible to switch to another opioid in an equal dosage. This is called opioid rotation. After switch, usually 75% of the equal dose is given to prevent overdosing. Opioids can be stopped cold turkey, because this will lead to withdrawal symptoms. This can be prevented by slowly tapering down the dosage until completely stopping. In summary, opioids are strong painkillers that primarily work through the agonistic effect on the mu receptors and are usually used to treat severe pain. There are multiple preparations available, such as a liquid, tablets, or parenteral administration. Optimal treatment of pain can be tailored to a specific patient with these different preparations and the individual effect profile. A decreased liver function may be a reason to lower the dosage or dosing frequency of opioids. A decreased renal function may be a reason to lower these for morphine specifically. Well-known ADRs of opioids are obstipation and respiratory depression. Interaction with medicine that depress the central nervous system worsen the ADRs, but naloxone can function as an antidote. Furthermore, reducing the dosage in small increments is crucial in order to prevent withdrawal symptoms.